Good evening and welcome. I'm Nora Kane and I'm the director of the Stanford Health Library. And it's my pleasure to have you here this evening for our second talk in the series on recurrent pregnancy loss from the Stanford Recurrent Pregnancy Loss Program. Tonight's topic is fertility and pregnancy loss research at Stanford. We have three speakers and then a fourth panelist for the question and answer period tonight. And before we get started, I'd just like to tell you that at the bottom of your screen, there's a Q&A button, and you can click on that. And if you have questions throughout the program, enter your questions, and they'll be answered either as we go along or during the panel at the end of the talk. Tonight's speakers include Dr. Gaya Mudugappan, who's an instructor and women's reproductive health research scholar. Her current research uses big data to understand long-term health outcomes of infertile women. Dr. Mudugappan is the director of the Rose Biobank and medical director of the Renew Biobank, repositories of excess embryos and tissue generated during clinical treatment for future research. Dr. Ruth Lathi is a professor of obstetrics and gynecology at Stanford University, and she's been on the faculty since 2003. She's the director of research for reproductive endocrinology and infertility, and the founder of the multi-specialty recurrent pregnancy loss program at Stanford. These programs include over 20 faculty members from 9 different subspecialties and is dedicated to the holistic care of families with pregnancy loss and the advancement knowledge through fertility and pregnancy loss research. Stanford is currently enrolling for 5 clinical studies in the field of reproductive medicine, genetics, and maternal health after fertility treatments. Dr. Virginia Winn is an associate professor of obstetrics and gynecology and a maternal fetal medicine specialist. She is the director of the Reproductive Stem Cell and Perinatal Biology Research Division. Her passion is the human placenta, which she has been studying for 20 years. Her mission is to understand both normal and abnormal placental development in order to improve maternal and fetal health. She has multiple NIH-funded studies and works closely with the reproductive endocrinology and infertility faculty. Dr. Bo Yu is an assistant professor in RAI at Stanford. She does translational research related to assisted reproductive technologies and epigenetics. Her clinical research in sickle cell disease and fertility will be mentioned as one of the projects tonight. And now that we've introduced everyone, Dr. Mudugappan will begin. So thank you.
Take it away. Hi, everyone. Thank you so much for being here tonight and joining us. We are really excited to share this talk with you. It is entitled, as you know, Fertility and Pregnancy Loss Research. And Ruth, if you could go to the next slide. This is just a reminder, one part of a 3-part lecture series. So on February 11th, we presented an approach to recurrent miscarriage. Today is talking about research. And then please consider joining us on March 11th to talk about the emotional journey of pregnancy loss. We have a really awesome lineup of speakers tonight. I will be kicking us off by talking about an introduction to research and talking about why we do research. Dr. Lathi will then follow by talking about examples of past and ongoing research in our division. Dr. Winn will then talk about what it means to be in a clinical study. And then we will wrap up and welcome any and all of your questions. As a reminder, and as Nora had previously said, please type your questions into the chat so that we can be sure to answer them. And all of the speakers, as well as a panelist, Dr. Yu, will be joining us for that portion. So my part is to talk to you about what is research and why do we do it. So research is really how we continually improve clinical care and treatments. And research for all of us starts with a need that we identify when we see patients in clinic. And from that clinical need, we then develop a research question. And from that question, we develop a very thoughtful plan of how to investigate and then test that question and scientific hypothesis, which after a scientific period of discovery, ideally results in improved care. And that improved care then in turn answers the clinical need that originated the question. And research essentially is divided into lots and lots of categories. I highlighted 3 large ones here just to kind of overview it. So there's basic science research, there's clinical research, and then translational research. And I'll touch a little bit on all of these aspects as we go through the talk. Before I get too far into the weeds and the details, I did want to just take a moment and comment from a 10,000-foot view that all of us here tonight are part of the Stanford University, and Stanford has really an exceptional commitment to research that I wanted to just take a moment and discuss. So Stanford has 18 independent laboratories, centers, and institutes that engage faculty and students from across the university. They have 20 libraries that hold over 10 million volumes of books and journals and databases, and a very large research budget, and most importantly, a culture of collaboration that really drives innovative discoveries in areas that are vital to our world, our health, and our intellectual life. I'll then zoom in just a little bit from the Stanford the overall view to the Department of Obstetrics and Gynecology, which of course we are a part of. But our department also has so many other divisions that are doing really interesting research. I just wanted to give you a small flavor of what they're doing, and happy to answer further questions if this piques your interest. So the Family Planning Division is working on expanding access to abortion and contraception through research that challenges the status quo. The GYN Oncology Department is working to advance cancer care through novel therapeutics and surgeries. The Division of Maternal and Fetal Medicine is focused on advancing the care for maternal, placental, and fetal disorders through interdisciplinary exploration and collaboration. The Division of Reproductive Stem Cell and Perinatal Biology builds really amazing interdisciplinary research programs that look at mechanisms of human reproduction, pregnancy, and stem cell applications. The Urogynecology Department focuses often on issues that present later in life that influence pelvic health, and they approach these in really compassionate and novel ways. And then the last division, which is my favorite, but I'm biased, is ours, which is the Division of Reproductive Endocrinology and Infertility. So I want to talk a little bit about things that are going on there, and Ruth will talk more about it. So basic science research, which is, as I mentioned earlier, a component of research that occurs. This particular type of research takes place primarily in the laboratory, and it has really led to groundbreaking advances in assisted reproductive technology, which we use every day, and also our understanding of human reproduction. So this slide is a snapshot of Dr. Bo Yu's research, who's a panelist tonight, and it depicts fallopian tubes that are being processed into fallopian tube organoids, which are these incredible three-dimensional cellular structures or reconstructions of the human endometrium that live in a petri dish in the lab. And these allow us really novel opportunities to study tissue biology and disease. And the picture on the right is a view of this organoid under a microscope. So you can see the incredible complexity of these structures. And Dr. Yu will be using this organoid model to study ovarian cancer. So pivoting a little bit from basic science research, I'd like to discuss now clinical research. So as shown in this pyramid, there are many types of clinical research, and each type has very unique advantages and disadvantages. So for any type of clinical research, when we have a specific study question or hypothesis, we ask ourselves, what is the best study design that will answer my question? Which also, number one, minimizes potential harm or exposure to our patients, and also is the most cost-effective approach. So the tiers of the pyramid kind of take into account different pros and cons of each approach. So if you look at the bottom in the red tier, case reports, you've probably read them. They describe small groups of patients and characteristics or outcomes that occur in a particular disorder. And then if you look a tier up at cohort studies, these are perhaps the most commonly done studies. And these take a group of people who do and do not have a particular exposure or disease and compare a specific outcome. For example, I recently did a cohort study looking at women with and without a diagnosis of infertility, and then compared the incidence or occurrence of pregnancy complications in these patients. So these types of studies can be done either looking forward in time or backwards in time. You can imagine that looking backwards in time is much easier to do, but the results can be affected by bias. For example, if you wanted to look at the association, for example, of a medication and birth defects, and you called 1,000 women who had children with and without those defects, you could imagine that those who had children who were affected are more likely to think about medications they took during pregnancy, just as a flavor of sort of the kinds of things that we think about when we design a study. And finally, controlled trials are a type of study that involve a specific exposure, for example, a treatment or a medication, and look for the development of a particular outcome. Dr. Lathi will shortly be presenting a randomized controlled trial that she is leading on embryo transfer cycles. And at the very top of this pyramid are evidence-based guidelines. And these are really kind of the pinnacle or summary of all these other types of research that are informed by panels of experts who review all the evidence from various studies and provide guidance for how we care for our patients. Next slide, Ruth. So then the question is, from all these different tiers of the pyramid, all the different things that are happening in and outside the laboratory, when does research really become clinical practice? And the short answer to this question is it takes a very long time, and science moves slowly. And that is because a single study rarely provides all the information that you need to make an informed decision. And evidence in the scientific process is synthesized slowly over time. And what's really important is that critical appraisal of these studies, like I had gone through just very briefly, is very, very necessary to adequately conduct the scientific process. And eventually, all of this culminates in us being able to practice evidence-based medicine guided by the consensus of experts. And you probably have heard us, talk in clinic about the American Society of Reproductive Medicine. And this is a nonprofit organization that is dedicated to the advancement of science and the practice of reproductive medicine. And they provide for us clinical guidelines based on research that people like us do that essentially inform clinical care. I want to take a moment and perhaps on a more personal note, just talk about why all of us on the faculty do research. And the answer that all of us would say right away is because research brings us tremendous happiness and fulfillment. And it's for a variety of reasons. Research allows all of us to engage in lifelong learning. We really do learn something new every single day as a researcher and a scientist. Research also allows us to forge really unique collaborations and partnerships, not only in our department, but also across other departments and schools at Stanford. Research also allows us the ability to challenge norms. And then by far most importantly, research allows us to provide the best patient care possible. And then I just wanted to end on a note of how this relates to you. So how does research benefit you as a patient? And, I think all of us feel that being actively involved in research ensures that you as a patient are getting the highest quality patient care. And there are lots of different types of research that you can engage in. And some of those studies have the potential to directly benefit you, but all of them, no matter what type of study they are or where they're taking place, all of our studies have the opportunity to contribute to the advancement of knowledge. And I just wanted to take a moment and thank all of you for being here and for considering participating in our research. And I'll turn it over to Ruth now.
Well, again, thank you, Dr. Murugappan, and to all of you who are joining us here this evening. As Nora mentioned, I've been here at Stanford since my training 20 years ago, and I've really had the privilege of seeing some of the research that we do turn into changes in our practice. And I wanted to share first, just historically, some of the things that I have seen over my 20 years here and how our team and our predecessors here at Stanford have really contributed to improving women's health. So one aspect of women's health that we work on, spend a lot of time on in our division is the use of in vitro fertilization. And Dr. Baer and Dr. Mielke were pioneers in extending embryo culture. When I came as a fellow, we were doing embryo transfers on day 3, and we were transferring anywhere from 2 to 6 embryos at a time to try to get one baby. Now with extended culture, we're getting higher pregnancy rates, transferring 1 embryo, and decreasing our risk of multiple births, which is our main goal, is to end up with healthy babies and healthy moms at the end of our treatment. So if anyone's doing in vitro fertilization today, the vast majority of you are likely getting embryos transferred at day 5, and that's thanks to the innovative work done here on embryo culture at Stanford. Additionally, some of our cohort studies have identified the link between certain environmental toxins and miscarriage. This research was done using banked samples. Nobody had to do anything extra. We just went into our tissue bank, pulled out some samples, and were able to show very strong correlation with environmental toxins and unexplained miscarriage, which has led to improved legislation for decreased use of these toxins in reproductive, actually in our environment in general. Additionally, we've examined the impact of the uterine microbiome on miscarriage. Our team was actually the first to report a live birth after genetic testing of a frozen embryo. And again, if any of you are in the field now, you will know that testing a frozen embryo is pretty commonplace now. So it's really exciting to hear that nobody even thinks of that as research anymore. Additionally, we were the first group in the United States to report a healthy live birth after the transfer of an embryo that tested abnormal in the tissue, in the embryo biopsy. This was just highlighted the fact that what we're doing is not perfect. And the consideration of transferring aneuploid embryos has led to the birth of over 200 healthy babies in the US since this first report. So we're real proud of that. Additionally, patients within and from outside of Stanford do have the option to donate surplus embryos to research, which can be used for a number of different innovations, including the creation of stem cells for research as part of our Renew Biobank. And lastly, through collaboration with our urology colleagues, we've made some novel associations between men's health and pregnancy outcomes, such as miscarriage and preeclampsia. So that's looking back. I want to take a few minutes this evening to talk about some of the studies that are ongoing at Stanford that are available to patients to participate in, or really just, root us on as we do some of this research to try to answer some of our important questions in fertility and maternal and child health. So just some of the interests of our team and include, but are not limited to, implantation disorders. So this is the time when an embryo meets the uterus and begins to merge with the mother system and form the early placental system. Implantation disorders, even beyond just helping us understand fertility and miscarriage, are also linked to later pregnancy complications, which we'll discuss in a little bit. We've noticed some interesting trends in maternal health after infertility and infertility treatments that we're trying to further investigate to understand the origins and hopefully mitigate and improve health outcomes for moms and babies after fertility treatments. These include changing our medication protocols. Preeclampsia is a topic near and dear to Dr. Winn's heart, particularly as it is for all of us, as it is a very common cause of maternal complications in pregnancy and can cause some serious health concerns for the mom and the baby. We're interested in causes of miscarriage, pregnancy loss, as well as endometriosis. So briefly, I'll give you some brief overviews of the studies that we are currently enrolling or plan to be enrolling soon for here. And we want to make sure that we answer your questions at the end. So just a brief overview of what the study's about. And we really encourage your questions or you to reach out to us after the seminar if you have questions about participating. So one study is called PERFORM, Predicting Endometrial Receptivity for Optimal Reproductive Management. That's what PERFORM stands for. What we know so far is that although IVF treatment has led to increasing live birth over the last several decades, still only 50 to 60% of normal appearing embryos lead to live births. And we don't know what is the cause of the other 50%. So we don't know if there's embryo problems or uterine problems. But we are performing the study using the highest quality embryos that we can find through IVF and genetic screening of embryos, and studying the endometrium and the environment during the window of implantation. These there's a single study visit for this, where an endometrial sample, a blood and urine sample, will be taken, and we're studying these samples for signs that predict the outcome of the embryo transfer, which is typically performed 1 to 2 months later. Participants will ultimately get the results of their tests if they're interested, whether they succeed in their embryo transfer or not. This is what we call our PRP study, platelet-rich plasma, for the treatment of recurrent implantation failure. So as I mentioned, we have about a 50 to 60% live birth rate per embryo transfer, but there are some patients who don't succeed after 2 or more transfers, and these patients are considered recurrent implantation failure patients. This is actually an interventional trial where patients will be randomized to receive either an infusion with platelet-rich plasma or placebo, and we will be able to investigate the impact of this infusion by comparing outcomes between the 2 study groups. So preeclampsia research. Preeclampsia is one of the more common complications of pregnancy and delivery, and affects about 5% of pregnancies in the general population. And our patient population at Stanford is probably more like 7 or 8%, mostly because the patient populations are referred in, and there's tend to be slightly higher risk. We've noticed a trend that preeclampsia seems to be higher after IVF and frozen embryo transfer. But what causes preeclampsia is largely unknown. It's thought to be related to the environment of implantation, something that's happened very early on when the placenta is developing. And this area of research is very important because it can have lasting impact on maternal and child health. We're investigating the impact of various treatment protocols on this unexplained disorder in our study called NATPro. Participants in this study are assigned to receive one of 2 commonly used medication protocols, and followed very closely with blood work and medical record review during their pregnancy. Patients to participate in this study must already have embryos in storage, and are planning to transfer embryos. They have to be, our female patients have to be between ages of 18 and 42 and have relatively regular cycles. This is a large multi-center randomized controlled trial, what we call sort of our gold standard in medicine. And there are 7 fertility centers recruiting for this study. There's a very nice website called natprostudy.org if you want to learn more, or you can just reach out to any of us on the Stanford research team as well to get more information. A follow-up study on preeclampsia is to really ask this question about how does the experience of having preeclampsia in your pregnancy lead to later cardiovascular health or cardiovascular problems. It seems in observational studies that women with preeclampsia do have a higher risk of cardiovascular disease later on. And what we're trying to understand in this study is, what is the biological link? How can we predict which women with a history of preeclampsia will develop cardiovascular disease? And this will help us identify ultimately preventative strategies and interventions that can improve women's health. So women with or without a history of preeclampsia are welcome to enroll in this study. And about half the participants will be enrolled during pregnancy, and then half will be enrolled at least 2 years after their last pregnancy and delivery. For this study, visits include blood and urine collections and some ultrasounds to look at blood vessels in the neck. This study also is, you can learn more about it in the website that's listed here. EPOC stands for Effect of Preeclampsia on Cardiovascular Health, EPOC study. You can go to this website and actually fill out some questions to see if you're eligible to participate. But we need healthy women to volunteer for this study for us to understand this important disorder. As I mentioned, our team is also very interested in understanding the cause of miscarriage and recurrent pregnancy loss. We know that miscarriage is the most common complication of early pregnancy, affecting 10 to 20% of all pregnancies. Roughly half of the pregnancy losses can be explained by testing that's available today. So we often will start by screening to see if there's any chromosome problems with the embryo. Unfortunately, half of these pregnancies are still unexplained, and we believe, based on our past research, that it's probably due to a combination of genetic and environmental factors, but we really don't know which they are. So our group was recently awarded a large NIH grant to study this problem. That study is called TRIOs, and a TRIO is a genetic term for analyzing parents and offspring. So it's a trio analysis of recurrent pregnancy loss using integrated bioinformatics and a genomic study. So pregnancy loss tissue will be sequenced, as will the parents, and we'll use our bioinformatics to try to understand and identify novel genetic causes of pregnancy loss, as well as how our environment and immune system interact with our genetics to lead to miscarriage. So this study requires access to miscarriage tissue or DNA that is either banked prospectively as these miscarriages are happening, or these miscarriages may already be in our bank. You actually do not have to be an active patient at Stanford to participate. And we're not yet open to enrollment, but we will be open soon. So patients and families who are interested in learning about this research can email our team, and we'll just keep you on our list for when we are open. We'll start enrolling shortly. Sickle cell. So sickle cell and female fertility, we don't really know for sure the risk between this genetic blood disorder and female fertility. Sickle cell disease is an inherited blood cell disorder that causes vascular occlusion, pain, and anemia, and can cause multiple organ damage. There are a few studies that seem to indicate early loss of fertility. And the purpose of this study is to evaluate the causes of ovarian aging and to hopefully identify fertility preservation strategies for women who are affected by sickle cell disease. So any patients who have sickle cell disease between the ages of 18 and 42 who are interested in participating will help us understand this. They'll have fertility testing done every 6 months for 2 years to look at over time. And for candidates who are eligible, we may be able to freeze eggs or embryos to help preserve fertility for these women with this rare disorder. So this is open to enrollment. So please reach out to us if you know anyone who's interested or curious about it. And then lastly, Dr. Murugappan is the director of our Rose Biobank. One of the more limiting factors in clinical research right now is the availability of samples. So we've built this biobank of reproductive tissues so that when we have a research question in the future, we are able to have a repository of already established and well-characterized tissues, blood samples that we can then query. We can ask our question. For example, the example I gave earlier, are reproductive toxins higher in women with unexplained pregnancy loss compared to those who have healthy births? And we were able to answer that question. The answer was yes. So we use stored samples to answer those questions. It accelerates our rate of discovery. When we have a question, we can ask it. We don't have to prospectively collect tissues. So really, any patient who's currently being seen in the Stanford Fertility Clinic or an OBGYN clinic can participate. And these patients don't have to do anything extra other than just consent to being in our research. And so when a patient gives a sample of blood or urine or pregnancy tissue or endometrium as part of their routine clinical care, once the clinical testing that your doctor ordered for you is completed, that tissue would normally be discarded. what we're asking in this bank is that once your clinical care is completed, that excess tissue can be put in a bank and can be used for research later. And a lot of discoveries are accelerated through the use of these banks. And so it may not seem like an exciting research project to be in because you won't know for sure who you're helping or how, but I guarantee you that these tissues are very valuable and help us advance women's health and men's health much more rapidly than we could without a bank. Additionally, we are accepting donated embryos from within and outside Stanford for couples who have excess or abnormal embryos that they no longer wish to use for reproductive purposes. And I'm going to thank you for your attention. I want to save some time for questions at the end. So I'm going to turn this next portion of the webinar over to Dr. Winn, who's a friend and colleague, who is an associate professor in the Department of Obstetrics and Gynecology, and she's the director of reproductive stem cell and perinatal biology here at Stanford, a wonderful researcher, and is going to tell us what it's like to participate in a research study.
Hi, good evening, everyone. Happy to be here and look forward to the questions at the end. So why do people decide to participate in research? I think the ones that I typically hear is really altruistic, of helping others and helping advance health and better care for the future. Contributing to advancing science is another real motivator for a lot of participants. Sometimes it's the study provides access to tests or treatments for free or at a reduced cost, or tests or treatments that aren't available outside of a study. And fourthly, most studies will provide a little financial compensation for the time and effort of helping to contribute to the work. So one question that a lot of people have in participating in research is how is it regulated? And there are institutional review boards that actually review all research that is done at Stanford to make sure that participants' safety, health, and privacy is protected. Also, none of the studies that we are currently performing detract from one's standard of care treatments. So it won't harm the standard of care treatments that you would receive. And in terms of the privacy piece, all of the data is required to be kept on encrypted, password protected, secure devices or servers. And many of the studies, and as much as we can, we de-identify information so that people's privacy is protected. This is particularly true for the biobanks when samples are given to researchers. Key clinical information goes with the sample, but not things that would allow them to identify who donated the tissue in the first place. And then I think the next area that a lot of people have questions around is in this time of a pandemic of COVID-19, what are we doing to help protect the health and safety of our participants? Stanford has put into place many protocols. All of the research has had to go through a COVID-19 committee review before it's allowed to move forward. At this point, all of the staff that interact with participants are vaccinated. All people who interface with the participants are required to perform daily health checks and we are all screened on a weekly basis. There are enhanced sanitation measures in all of the facilities, whether it's research or just standard clinical care. We continue to use masking and social distancing as much as possible. And the IRB, or the Institutional Review Board, has helped facilitate being able to do as much of the research remotely. So rather than consenting in person, many of the studies now can do consenting electronically. So that has been a shift in how we carry out research. Also using a lot of surveys electronically rather than on paper. And frankly, I actually feel safer at Stanford than I do anywhere else in the community because of people really are exercising, masking, social distancing, and there's sanitizer everywhere. Your hands are always clean. So that's what's being done in terms of how we've adjusted things because of the pandemic. And here is just a list of some sites that you can go to learn more about research here, or search the clinicaltrials.gov is research studies across the whole country. And so we'd love to hear from you with questions or inquiries. And then the next slide. Just a refresher of the multidisciplinary team that Dr. Lathi has put together to come to help not only with the clinical care, but also to advance our understanding on the research side of pregnancy loss. So want to thank you for your attention. The Stanford Health Library team has the recording of the earlier first lecture. We'll have a recording of this lecture as well as the one on March 11th if you're not able to attend in person. So please check these out at healthlibrary.stanford.edu. So now we will go to the question and answer period.
Okay, there's two questions in the box. One, does Stanford do embryo transfer of aneuploid embryos? Yes, this is a study that we started here at Stanford maybe 2 years ago, where we're prospectively enrolling patients who are asking about transfer of abnormal embryos. And for the group who may may or may not know about the background here, the use of genetic testing of embryos has become more and more common as an adjunct to IVF. But what we've noticed is there are some limitations. So sometimes the test, there'll be an error. So we don't encourage the use of aneuploid transfer as a first line, but if there are no other options available to that patient, we are exploring ways to help these couples have healthy births after aneuploid transfer. And we would accept patients who are being seen at other clinics if they want to transfer their care to our clinic to participate in this trial, but they must be a patient who's actually being seen at Stanford for this trial. And it's called the TAME trial. You can learn a lot more about it on both our website, the Fertility Research at stanfordchildrens.org, or you could go to clinicaltrials.gov. It's registered there as well. The next participant asked if patients can participate in our trials if they live in another state or metro area. It does depend on the trial. In some cases, we are allowing patients to self-refer from outside of the Stanford system. And in others, they have to be already within the Stanford system. So for example, our Miscarriage trial or our Trios trial that I mentioned will allow patients from all over the country to participate. And we will likely have a couple of other recruiting centers if patients want to go locally for that one. So keep an eye on our website. We'll be posting more information about that trial. All right, next question. Is there a way for patients to find out the outcomes of these studies? And thanks for a great talk. Well, thanks for joining us. The best way to learn about our studies and the outcomes is a couple of ways. So when a faculty member of our team publishes a paper, it appears in their CAP profile. On clinicaltrials.gov, we are posting updates occasionally as needed. I think that we post updates about yearly on the clinicaltrials.gov website. Who would qualify for the study involving transfer of aneuploid embryos? There's a list of qualifications on our website or on the clinicaltrials.gov website. So again, go to if you go to that fertility research at stanfordchildrens.org, there'll be a link to each of the studies, and the particular inclusion/exclusion criteria are going to be there. But essentially, anyone who has exhausted their other embryos and has only aneuploid embryos left is eligible for this study, with a few minor exclusions. All right, I'm going to give a question to someone else. So what factors can increase the success rate of frozen embryo transfers? Dr. Murgopin? Any suggestions?
What factors can increase the success rate for frozen embryo transfers? I think a lot of it starts with the IVF lab and the way that the embryo is handled and created and stored. And we are so fortunate at Stanford to work in such an amazing laboratory. I think also the age at which the embryo is created is very important. And then we work really hard to optimize the protocols that we use to prepare the uterus for embryo transfer. And that's one of the studies Dr. Lathi mentioned is also an area of ongoing investigation.
How is genetic testing done of the embryos, and is there a risk of damaging the embryos? Dr. Yu?
Yeah, so currently the genetic testing is done when after the embryo reach 5 to 7 days in a petri dish, and we take a few cells from each embryo and send for genetic testing. So there is a small risk for damaging the embryo, but the risk is very small. Usually the risk is less than 5%. Currently, we're trying to develop some non-invasive genetic testing methods. That's an active research area.
Yeah, stay tuned for that. We'll be posting about that. Next question, is a chemical pregnancy considered a pregnancy loss? I think in the medical literature, this is somewhat debated, but as a recurrent pregnancy loss expert, every pregnancy counts. So if you come to see us in our group, we count every pregnancy. Sorry, they're going here quickly. If I skip one, I apologize. Is there information or studies done where frozen transfer medication protocols are customized? Yes, this is definitely an area of active ongoing research. And in our PERFORM study that we mentioned, we are actually trying to individualize find ways to individualize our approach. So much of our infertility and implantation failure is unexplained. We're looking for clues that will tell us how best to customize. But there's an area of active research at this point. As opposed to the standard protocols used across the board. Oh, this is a continuation of that. I'm not exactly sure what this person means. So I think what you're talking about is what we kind of use this term called personalized embryo transfer. So there is a standard approach in terms of the timing of the window of implantation, and then There are some tests that might indicate that we need to personalize our approach for patients. So these studies currently are extremely small and not well validated. And that's why we're trying to do larger and more systematic studies, such as the PERFORM study, where we're prospectively looking at a wide variety of patients so we know who benefits from these types of tests. A question here. My wife and I are going to transfer our only viable embryo in about a week. Good luck. I hope it goes well for you. If that doesn't work, would we be able to participate in a study with aneuploid embryo after that? Absolutely. If you're a patient at Stanford, then you can just reach out to our Stanford genetic counselor who will review the inclusion-exclusion criteria with you. But if that's your last remaining embryo, then it is an option for you to consider our trial versus do another retrieval round. Thank you, Sergio. The next question is, do you have patients with mosaic Turners? Yes, we do. This is a condition of that often causes ovarian dysfunction. And so we do see it at all ages, where we try to help with fertility preservation and fertility treatments. Do you have a trial to redo Pgta test on an abnormal embryo given the false positive rate? Currently, we do not have this trial. The reason we don't recommend repeat testing of an embryo once there's an abnormality is this concept of embryo mosaicism. And that means that some of the cells in the embryo are normal and some of the cells are abnormal. So that's the main reason of that we think we get this false positive, that it's not that the test is picking up the wrong thing, it's that a small number of cells are abnormal, and by random chance we picked some abnormal cells, but the other cells are normal. So even if we test another cells in that embryo and that second group of cells is normal, we still are dealing with the abmosaic embryo. So we counsel patients as if the embryos are a mixture and review those risks rather than retest the embryo. The other downside of retesting the embryo is that we see that embryos lose viability significantly after their second biopsy. So a healthy embryo that might have been able to implant after a first biopsy, after a second biopsy, has a lower chance of pregnancy. So it doesn't remove the concern of mosaicism, and it potentially harms the embryo. So we're currently not doing that as part of our study. These are great questions. Let's see, anyone else have questions? Maybe Dr. Winn, can you tell us a little bit more about your preeclampsia research, since I know you know much more about your studies than I do. So tell us more about the preeclampsia research.
So the EPOC study is actually trying to understand what happens over 20 to 30 years. So we're actually taking kind of a novel life course approach for that study, and actually studying women in pregnancy and immediately postpartum. So women who enroll in EPOC during pregnancy will have 2 study visits. Then we're enrolling women 2 to 10 years after they've had pregnancies to see how their cardiovascular health advances with age in the context of whether you had preeclampsia when you were pregnant or you had pregnancies and didn't develop preeclampsia. And then we're using banked samples. This shows the power of biobanks that have samples that are 20, 30 years old that have been banked, that now we know the health outcome of those women, and looking at what was different in their blood earlier in their life, now knowing who got cardiovascular disease and who didn't. And we're actually, the women that participate, we're actually doing a tremendous amount of cutting edge. We've got 13 laboratories at Stanford that are actually contributing to analysis of the blood, the urine, the placenta, the cord blood, and then also the vascular studies. Women will get their cholesterol and lipid levels tested, their glucose levels tested, and their urine protein evaluated as well. And anybody who has abnormal values or were concerned about their cardiovascular health, we have a great women's cardiac health clinic that we can refer people to.
Wonderful.
A little bit about that study.
That's fascinating. Sounds like a benefit to participants and women in general too. There's a few questions that are kind of appearing in a different area here. How many chemical pregnancy losses considered a recurrent pregnancy loss? Again, definitions will vary. We tend to start evaluating after 2 or 3 and take our evaluations depending on a lot of other factors, such as the age and the underlying fertility of the couple. Question, I don't know if everyone can see the question, so I'm going to read them here. Maybe for Dr. Murugappan, is there something that can be learned from the genetic abnormalities that appear? 2 miscarriages and 2 out of 2 IVF blasts were genetic abnormalities, but they were different mutations. Is there anything that contributes to this other than egg quality?
Thank you for your question. When we see multiple genetic abnormalities from a batch of embryos after genetic testing, we always do wonder if there is something that is actionable there. Unfortunately, in the vast majority of cases, the genetic abnormalities are just random bad luck. They're just the egg at the time of fertilization. It has twice the amount of DNA, and it has to, in a very rapid sequence, perform a very complicated series of divisions, of cellular divisions, and that machinery fails a lot. And so the vast majority of the time, it is not an actionable error.
Yeah, and they have been known to come from sperm as well. I think in some studies, but often, we don't know. And this is an area of active research. And as part of our program, we're going to try to understand if there are some environmental factors such as inflammation or other exposures that make one couple have more of these chromosome abnormalities than others. Let's see. What ethical considerations of transferring an aneuploid embryo? Well, this did take some time to get through our review board. So the anytime we're looking at a question, we and especially in research and in reproductive medicine, we really have to place a very high value on patient autonomy and give them the right to make their own choice about their body and about their embryos and about how they want to reproduce or choose not to reproduce. We feel strongly in those values in our clinic. So the balance of ethical considerations are, what are the harms of transferring an abnormal embryo versus what are the potential benefits of transferring an abnormal embryo? Or you could say, what's the harm of transferring the embryo versus what's the harm of not transferring the embryo? And so what we do know, and as we're balancing this, and I'm not an ethicist, but just to give you just a brief idea of the things that were considered in this. So the value of not transferring the embryo is that we are taking no risks with doing nothing has the least risk, I guess. There's always the risk that one of these abnormalities could lead to a birth defect or a chromosome problem in an ongoing pregnancy. Some chromosome abnormalities are more likely to fail to implant or to miscarry. So the benefit, the harm of not transferring it is that some of these embryos, and it's estimated to be up to about 4 to 5% of these embryos that are diagnosed as abnormal are made in error. So we're discarding 4 to 5% of embryos that could potentially have the benefit of a live birth. So these are some of the things that we really had to balance when we're deciding to do this study, and it's done in combination with our ethics colleagues, as well as very careful counseling to couples about the risks, the benefits, and the alternatives to participating in transfer of an abnormal embryo. And a lot of our families who are asking for this option, once they learn the risks and benefits, choose not to, and that's completely fine with us. And others really have sought out this option because it's very important to them to give those embryos a chance. Even if it's a low chance, they're willing to take a risk because they feel that they don't want to, close the door on those embryos without giving them a chance. So it's a very personal decision. And this study really came about because of really significant patient demand and pressure from patients who wanted this option. And we felt the most ethical thing to do was to do it as part of a study so we really could learn and get the most that we could out of counseling our future patients about the health of this option. And so these families who are doing this study are brave and passionate about proceeding with these transfers. And we do our best job to explain and learn as we go along. Does anyone see other questions?
Yeah,
There's
there's another question, so I'm going to direct that to you, Ruth.
Oh,
What are the primary and secondary objectives of the NATPRO study?
So there's really two. One, as we mentioned, we've noticed in observational studies that frozen embryo transfer is associated with higher risk of preeclampsia. So we're trying to examine the rate of preeclampsia in these two commonly used protocols. Is it more prevalent in our programmed cycle, or is it more prevalent in our modified natural? So that's really the impetus for trying to understand preeclampsia and frozen embryo transfer. Secondary outcome is live birth and other pregnancy complications. So we really are trying to, have come a long way in getting a lot of people pregnant with IVF and frozen embryo transfer. Now we're just trying to eke out healthier babies and healthier moms. And so we can optimize how we do our treatments to give people the best outcomes. Did I miss anything? Those are the main ones, right? Okay. And then I see questions popping up in different places. So I feel I'm not in order.
There's a question I wanted to address about, are there trials going on or services available for recurrent pregnancy loss that do not involve IVF or embryo testing? And I wanted to thank the person for asking this question and just point out that Ruth has really created an incredible multidisciplinary program here to approach pregnancy loss from a very comprehensive and holistic approach. So we not only provide fertility services, but we recognize that pregnancy loss affects you in every aspect of your life. And so we have psychiatrists. We also have a really large team of subspecialists in hematology, endocrinology, rheumatology, who we have access to. So please consider that.
Yeah. Additionally, our TRIO study, which will be open for enrollment soon, does not require IVF. In fact, we're profiling parents and family members and miscarriages genetically and biochemically to try to predict pregnancy outcomes. And we actually are hoping that the majority of the subjects and families in that study are not doing IVF. IVF is allowed, but it is not the focus of it. So as Dr. Winn mentioned, we are not going to be withholding or forbidding any standard of care treatments such as IVF if they're indicated, but the study is really around the genetics and the environment of repeat pregnancy loss, independent of any treatment that may be indicated for other reasons. So for recurrent pregnancy loss, I would definitely encourage you to reach out if you're interested to be contacted when we're ready for that study. Additionally, as part of the biobank, that we are banking these tissues now for future research. So patients who are going through pregnancy losses now can donate their blood to our biobank, and or if they have a miscarriage, that tissue can also be banked for future research and is extremely valuable to us and the field.
Okay. Ruth, there's a question here. I don't know if Gaia or you or Bo want to take it. I'm a 54-year-old. I've had 2 failed embryo transfers. Embryos are created from 27-year-old egg. Are there any studies being done for older mothers?
I have to look at the age limit for the PRP study. Maybe. I would definitely have you reach out and ask about it. I don't have Dr. Agajanova is the primary investigator for the PRP study. So it's a possibility that would be an age. Do you have the ages there? Reach out to us. That's one possibility. Another possibility is just some of the endometrial testing that is commercially available that we're investigating as well. Let's see. Do you have another? Somehow mine are just out of order. So it's genetic test. Okay, we answered that. 54. The trials for recurrent pregnancy that do not involve IVF for embryo testing. How common are birth defects with abnormal embryos? That is a very good question. We're trying to answer that in our TAME trial right now. I think that the risks will depend somewhat on what genetic abnormality we're talking about. So the majority of there have been over 200 live births from embryos that were tested abnormal in IVF, and either were mosaic or abnormal, and they were healthy at birth, meaning that there wasn't any apparent birth defects noted during the pregnancy or at birth, but the long-term follow-up is still lacking, and that's a pretty small cohort still. The thinking is that these abnormal embryos are due to the mosaicism that we mentioned, that there are some normal cells and some abnormal cells, and by just sampling error, or I don't know if error is the right word, just the limits of sampling a portion of the embryo rather than the whole thing, we're diagnosing the whole embryo as abnormal when it was just a small portion of it. And embryos are so plastic, they're so able to the cells are developing so quickly that the healthier cells can overtake the job of the unhealthy cells, and as the embryo develops, the healthy cells become more dominant, and that's how you get a healthy birth from an abnormal biopsy.
Actually, part of the reason of that is the cells that are biopsied are from the outer part, the trophectoderm. That's what placenta developed from. And the placenta tolerates genetic abnormalities much more than the fetus. And so if there is a mixture of cells, the placenta can still grow and develop, often with aneuploid or chromosomally abnormal cells, but nature somehow picks the healthiest chromosomes to develop into the baby. So in pregnancy, when we do chorionic villus sampling around 11 to 14 weeks for women who are wanting genetic testing at that point, about 4 to 5% of the tests have mosaicism, and that test is taking the placental tissue. And then when you do an amniocentesis on those, oftentimes the fetus is of a normal chromosomal makeup, a normal karyotype. So part of the reason is because the biopsy is coming from the part of the embryo that's going to form the placenta, and those get tolerated as being mosaic.
Okay, well, thank you all for your participation, your wonderful questions. We are here for you. Stanford Fertility, Fertility Research at stanfordchildrens.org is probably the best place to see a list of our currently recruiting studies. The email for our research team is there, and just email and ask anytime if you want, if you're wondering if there's a study you might participate in. This recording will be available through the health library if you want to go back and look at it again, or share it with your friends. Thanks again for spending your evening with us tonight. We really appreciate your time and participation.